Good morning, students. Today's class is on orthognathic surgery. I'll be talking about mandibular procedures commonly. Before that, we'll discuss classification. So, according to classification of dental deformities, or according to jaw involved, it is maxilla, mandible, combination or both. According to plane, you have transverse, vertical, anterior, posterior. According to this, also classified as skeletal, class 1, class 2, class 3. And class 1 dentofacial deformities, you can have vertical maxillary axis with open bite. Class 2, you can have dentofacial deformities secondary to mandibular deficiencies. Class 2 deformities secondary to vertical maxillary axis or combination of both maxillary deficiency as well as maxillary axis, and class 2 dentofacial with open bite. And class 3, you can have excessive mandibular prognathism or secondary to maxillary deficiency in 3 planes. And class 3 dentofacial deformities secondary to maxillary deficiency as well as mandibular prognathism, and class 3 with open bite. And conditions common to class 1, class 2, class 3 are transverse maxillomandibular discrepancies, bimaxillar protrusions class 1, class 2 and class 3. So types of surgery, we have mandibular surgeries, maxillary surgeries and combination of both. Today I'll be talking about mandibular surgeries. So mandibular surgeries, you have ramus osteotomy, body osteotomy, combination of both, subapical osteotomy and genioplasty. Genioplasty, I have discussed it in the previous class. So ramus osteotomy, you have osteotomy in the condylar neck, vertical osteotomy, vertical oblique osteotomy, inverted L osteotomy, sagittal split osteotomy and horizontal osteotomy in the ramus. So the body osteotomy, you have anterior body osteotomy, posterior body osteotomy. Condylar neck osteotomy, now we'll go into the details of the procedures. Condylar neck osteotomy was given by Berard in 1898. Advantage is simple to perform, shorter operating time and scarring is negligible, no injury to mandibular nerve and technique, teeth is not sacrificed. So you can see by the picture, there is a condylectomy done to shorten take back the chin posteriorly. I mean, entire mandible is taken back, bilateral condylectomy done and intentional open bite is created. Vertical osteotomy, you have given by Caldwell and Letterman in 1954. It is used for correction of prognathism for more than 10 to 12 mm. So this procedure is being described. The patient is in supine position and there is an extended submandibular incision given. Then a vertical cut is given anterior to antilingula, and which runs from the coronoid notch till the lower border of the ramus, and the entire split is done. Then the anterior segment is then morcellized and small burr holes are made so that bony bleed occurs. And then the entire split is connected, taking care of the inferior nerve. Once the split is completed, then both the segments are overlapped. And vertical oblique osteotomy, also called as subcondylar osteotomy or subcondylotomy. 2 types you have: extraoral, intraoral. Modification of vertical osteotomy, extraoral is given by Hyde 57. It can be used to correct moderate prognathism. So it is very similar to the vertical osteotomy, but there is a cut is oblique. The advantage of this technique is less of proximal segment is sacrificed. So here, similar to vertical osteotomy, the cut is made and then the segments are overlapped. Now in detail describe intraoral oblique osteotomy, which is very popular till today, was given by Winstanley in 1968. The procedure is an intraoral vestibular degloving incision up to the coronoid notch is given, and inferior to the lower border is given, extending. Then a cut is made intraorally only, and a proximal segment is, minimal proximal segment is osteotomized using a contraangle saw, osteotomy saw, because you're doing entire procedure intraorally. And then the segment is mobilized and it is sufficiently skeletonized, and then overlapping bone plate can also be used, or wire fixation can also be done this way. You can see the wire fixation done this way. Then we have a most popular and most versatile procedure, sagittal split osteotomy. It is also called as BSSO, bilateral sagittal split osteotomy. It was given by Obigeser in 1957. Wide variety of changes and movements are possible. Surgical modification of traumatic factors, modified by dull point, and other modification done by Bell and Schneidel. It's an excellent procedure and very predictable. So in this cut, there are two limbs of the cut, three limbs are there in fact. One limb is the medial cut, then there is an anterior limb. The medial cut is given just above the lingula, avoiding the neurovascular bundle. And then there is a third limb, that is the vertical limb, which extends to the lower border. Once all these cuts are only gone to the initial cortex, and then the osteotomy is proceeded, splitting the proximal segment and a dental or distal segment. The nerve should be with the dental segment. And then you can do small sections. If you remove some part, you can do a setback. If you extend it, then the sliding osteotomy is proceeded. You can extend it also. Then there is inverted L osteotomy. Inverted L osteotomy appears something like this, extending from the ramus and then going back to the angle. This is outdated procedure, but can be done if there is an axis open bite along with axis mandibular axis, that is mandibular prognathism. Horizontal osteotomy of ramus was again given by Blair in 1907 and modified by Kazanjian. This is the horizontal. It's not used nowadays. It's outdated method. So body osteotomy, anterior body osteotomy, posterior body osteotomy was given by Blair in 1907. Extraction of premolar is done, and carefully dissecting out mental nerve, you can do a body osteotomy. Setback, you can do a posterior cut also, posterior body osteotomy. It's commonly done in anterior open bite cases. You can do a sliding. So these are all body osteotomies where wedge is removed and the chin is taken back. So distraction osteogenesis is another procedure which is very popular. It's done if the gap of the segment is more than 10 mm, where orthognathic surgeries have high rate of relapse. So technique that relies on normal hearing process, de novo bone lengthening by gradual controlled distraction. It was proposed by Elizaro, and this technique was adapted in maxillofacial surgery. It's an armamentarium in today's reconstructive surgeons. So a mandibular osteotomy, corticotomy can be done, and then it can be distracted slowly after a latent phase of 7 days, slowly 1 mm per day until you want the desired result, and then can be removed after 3 months. The appliance can be removed, or you can remove it immediately and bone plated. So severe deficiency like bird faces in TMJ, bilateral TMJ ankylosing cases, which require more than 10 to 15 mm, short mandibular lemurs, hypoplastic mandibular agenesis also you can use this. Next is a new system for computer aided preoperative planning and intraoperative navigation during corrective surgery. This is a adaptation of neurosurgical procedures into the maxillofacial region, where navigational surgery can be used to precisely do the surgery and analyze the important structures at that moment during surgery. Computer aided 3D planning can be done using a stereolithographed 3D printed models. You can perform the mock surgery on them and then do the surgery in the OT table. Thank you. The references are orthognathic surgery, essentials for orthognathic surgery, Johann P. Ranike, and current concepts and discrepancy, Open Journal of Stomatology. Thank you for having